I'd like to say a warm welcome to everybody to this webinar arranged by the Nordic Committee of Bioethics in cooperation with the Swedish Medical Ethics Council. This is a series of events. The first one was held from Helsinki with Professor Matti Heiri speaking and with two commentators. And we are going to use the same format in this series, and the Nordic countries, will alternate to organize a webinar for each country. And now it's Sweden's turn. The series is called The Ethics of the COVID-19 Pandemic Nordic Perspectives. We have much in common in the Nordic countries, but there are also obvious dissimilarities. And we think that we should use these similarities and dissimilarities as an entry into the question that we all struggle with now: how to make the best decisions, how to live individually and socially and globally in a pandemic situation, a situation that none of us had been into before. And there's a whole lot of choices to be made. So I would now give the floor to Sigur Kristinsson, who is currently the chair of the Nordic Committee on Bioethics. Please, Sigur.
Thank you, Ingemar. So I'm very pleased to welcome you all on behalf of the Nordic Committee on Bioethics to this second installment of our webinar series on the ethics of COVID-19 pandemic. The committee was founded in 1989 to promote Nordic cooperation and exchange of information between scientists, parliamentarians, opinion leaders, and public officials in the area of bioethics. The secretariat is provided by Nordforsk. Now, this committee is multidisciplinary, and it has 2 members from Denmark, Finland, Iceland, Norway, and Sweden, as well as observing members from the Faroe Islands and Åland. Now, among our regular tasks is the publication of an overview of legislation on biotechnology in the Nordic countries, but the main work of the committee is the organization of conferences on bioethical issues that are relevant to the Nordic countries. Normally, we arrange 2 and perhaps even 3 conferences every year. Now, this year is, of course, special. So because of the pandemic, we had to go online and quickly agreed that a webinar series on COVID-19 would be a good idea under these unique circumstances. I would like to thank the working group led by Truls Pettersson for organizing the series, and special thanks to Ingemar Engström, who was in the lead when it came to preparing today's event. And finally, many thanks to the Nordforsk Secretariat, as well as the Swedish National Council on Medical Ethics for their part in making this event possible. So next slide, please. In addition to the current webinar series stretching from October to March, the Nordic Committee on Bioethics is also organizing further events in the near future on the ethics of artificial intelligence in healthcare and research, and ethics and climate change. For updated information and registration, please don't hesitate to visit our webpage at ncbio.org. Thank you.
Thank you, Sigurdur. Now the floor is Lotta Eriksson from the Swedish Medical Ethics Council.
Thank you, Ingemar. My name is Lotta Eriksson. I'm Secretary General of the Swedish National Council on Medical Ethics. It's my honor to give this welcome address on behalf of the Swedish National Council on Medical Ethics and our chair, Kenneth Johansson. But first, I'd like to say thank you to the Nordic Bioethics Committee for taking the initiative to collaborate with the Swedish Ethics Council on this webinar. The Nordic cooperation between bioethicists and national ethics committees is of great importance. Many former members of the Swedish committee have also been members of the Nordic Bioethics Committee. I have followed the important work of your committee during, and also the many high quality seminars you have arranged during the 18 years I've been working on the field. We plan to take an initiative to arrange a Nordic meeting between national bioethics committees in September next year. And now we have the first slide, please. Yes, this one. So the Swedish National Council on Medical Ethics is an advisory body to the government and parliament on ethical issues raised by scientific and technological advances in biomedicine. And it also has a task to function as a bridge between politics, experts, and the society. Next slide, please. And the Council's work on the pandemic. So the Swedish Council has closely monitored the situation and have so far contributed with policy recommendations to government, parliament, and the authorities. In the end of March last year, a working group within the Council started to write on a report that were published in May, ethical choices in the pandemic, that Göran Collste will give you an address about today. And on these slides, you see some upcoming webinars on COVID-19 that we will arrange in the following months. So please join. And once again, many thanks for arranging this seminar together with us.
Thank you, Lotta. Now, without further ado, I would like to introduce our main speaker, who is Professor Emeritus Göran Collste, Professor of Applied Ethics for many years in Linköping. He's been very active also on the European level, not the least from Societas Etica, the European Society for Research in Ethics. He is now a member of the Swedish National Council on Medical Ethics and been one of the main persons behind the report that was made in May, which is called Ethical Choices in a Pandemic, which is also available in English on the Smer website. So please, Göran, welcome.
Thank you very much for welcoming me, and thank you for inviting me to this interesting, what can I call it, a club or organization or community, perhaps, Nordic people in the Nordic countries interested in ethics. Yes, I want to speak about ethical choices in a pandemic, a Swedish perspective. So that's the title of the report. And you can see that on my slide, perhaps, this title. Yes, here we are. And in Swedish, etiska vägval in pandemi. Ett svenskt perspektiv. So, what then is a contribution of ethics and ethicists when we face ethical challenges, as for example, the corona pandemic? Next picture. Perhaps this. Miss Dugan, will you send someone in here who can distinguish right from wrong? I doubt, though, that Miss Dugan will find anyone who can do that. So the ethicist's role is not to provide ethical answers, to decide what is right and what is wrong. No, in my view, the role of ethicists are to analyze values and value conflicts. Now we can take away, I don't have any more PowerPoint, so we can take away the PowerPoint. Decisions are based both on facts and values. We decide to do X because X leads to Y, and Y is something good. To illustrate, a doctor decides to treat a COVID-19 patient with remdesivir because she believes it will cure the patient. Remdesivir, X is a mean to cure Y. A cure is something good. Reasonable decisions require both well-grounded facts. For example, that X really leads to Y, and justified values. That is, that Y is something good. Sometimes we are more sure about the mean, sometimes we are more sure about the value. In this case, in this case that my example, maybe it's less sure that remdesivir will be a helpful cure. It is more, we are more sure that cure is something positive and valuable. Decisions are made by individuals, families, firms, everywhere, and authorities, institutions, governments, For example, decisions for a strategy to fight a pandemic. Our report, Ethical Choices in Pandemic, was written last spring. We worked in a group, Mikael Sandlund, who is a professor of psychiatry, Göran Hermeren, who has been a long time working with ethical issues in medicine, Nils-Erik Salin, who is a colleague now in Smer, and Lotta Eriksson, whom you just met, was the coordinator of the whole work. And the purpose was to analyze difficult ethical questions related to the pandemic. I will present some of the report now, and an interesting question is, of course, at the end when we have a discussion, is it still valuable, this report? Is it still relevant? We can come back to that question. I will first introduce some of the ethical principles that we present in our report. I will then say something about ethical challenges on a global level. Next, I will explain how a national strategy for corona mitigation presupposes ethical choices. I will then discuss some ethical challenges in healthcare and in research, and finally comment on the outcome of the corona pandemic in Sweden so far. As I mentioned, ethical principles and values are crucial importance for reasonable decisions. Therefore, the starting point for the report is some important ethical principles. We propose the following. First, minimize harm, save lives. Second, human dignity. Third, personal privacy, individual liberty. Fourth, justice and equity. Fifth, scientific basis. Proportionality, trust, and finally, solidarity. This is not just a random choice. These principles are found in the decision, in the discussion on medical ethics. They're anchored, we suppose, in public reason. They are, we argue, both justified and relevant, although, of course, they need both explanation and specification. I will come back to some of them in my presentation. Let me now say something about ethical choices at a global level. A pandemic knows no national borders, and a successful combat against it presupposes global solidarity. Present global inequalities become particularly evident in times of crisis. At the outbreak of the pandemic, no nation, perhaps with the exception of Finland, was prepared with sufficient stock of medical equipment, antiviral medication, other necessary means. This led to a race where the rich and powerful nations could harvest what they needed. It remains to be seen how the new vaccines against COVID-19 will be distributed globally. We argue for two principles that should guide the distribution of medical equipment, antiviral medication, and vaccines. First, a principle of global justice, implying equality and benefiting the least advantaged. And second, principle of international solidarity, meaning a unity between people and nations worldwide, with a readiness to provide mutual assistance. These principles are robust. Although global justice in practice is restricted, of course, by national interests, a principle of global justice can only be questioned by anyone who will argue that the lives of citizens in rich countries are more valuable than the lives of citizens in poor countries. And the principle of international solidarity would be questioned only by someone who prefers that egotism and self-interest prevail over cooperation and mutual support. Let me now turn from global to national ethical challenges. National decisions for corona mitigation entail many ethical choices. Some are explicit and some tacit. In our report, we try to illustrate this with the help of an ethical decision model. The government, at least formally, but in reality, perhaps in Sweden, the public health authority, that is Folkhälsomyndigheten, who has had a great influence on the Swedish policy, must decide what to do. There are different possible strategies, different paths to follow, from a lockdown of the society to softer measures like recommendations to the public. Different corona strategies will have different consequences. The number of persons infected and the number of deaths will vary. Different strategies will also in different ways restrict citizens' rights and freedoms, and the strategies will have different economic consequences. Decision makers must also consider the probability of the different consequences. This is normally very difficult, but of course even more difficult for a strategy to mitigate the corona pandemic, while the development of the pandemic is extremely unpredictable. How then do we value the different outcomes? Can, for example, safeguarding some fundamental freedoms outweigh an increased number of deaths? Perhaps this kind of choice sounds absurd. We must, of course, both try to save lives and protect fundamental freedoms. But this kind of balancing and choices are made implicit, and to make them explicit is a way to show that the choice of strategy to a large extent also presupposes ethical choices. So based on the identification of alternative paths and their consequences, the probability of the various consequences, and the evaluation of the different outcomes, a reasonable decision of strategy can be made. Perhaps, but we can say that reasonable and rational decisions making of this kind perhaps can be made in a utopia. We don't live in utopia, unfortunately, perhaps. In contrast, a real-life decision maker will be restricted by, for example, lack of information, problems to foresee consequences, and this is really true for the present corona pandemic. There's so fundamental disagreements between the experts on infection disease and epidemics. That's even for laymen quite surprising, but that makes, of course, the decision making extremely difficult. However, we can see from a decision model how we structure the decisions in this way, but it's crystal clear that it's not only scientific information, but also not only lack of scientific information, but also lack of ethical awareness and ethical reflection will impede reasonable decision making. So the reflection on ethics and the values are as important as the factual information. So Sweden has been a little different in the world. In contrast to most European countries, Sweden chose a softer corona strategy with recommendations rather than a lockdown. I think this strategy was probably supported by a majority of Swedes. At least there were some polls showing that, at least in the beginning. It has been, I think, motivated by with reference to the notion of folkhemmet. Folkhome, maybe it could be an English translation, I don't know. It's an image of a society as a whole, but it characterized by trust and solidarity. Ironically, though, Sweden has become an example for right-wing libertarian groups in other countries demonstrating against any restrictions of individual freedoms and rights. That seems to me quite really an unholy alliance. I will now turn from the question of national corona strategies to some ethical challenges in healthcare that we also discuss in our report. How should healthcare professionals weigh the risk of being affected themselves against the duty of care in a situation when protective equipment is lacking? How should healthcare resources be prioritized? How should patients with COVID-19 be prioritized in relation to other patients and ongoing treatments? And perhaps most controversial, how should patients be prioritized for intensive care? The question how to prioritize patients for intensive care was discussed in Sweden and I suppose, of course, elsewhere also in the spring of 2020. According to the Swedish law, three principles should guide priorities of healthcare. First, the principle of human dignity, saying that all people have equal value and the same rights, regardless of their personal qualities and their function in society. Second, a principle of need and solidarity. It states that resources should be directed to the person with the greatest need. Finally, a principle of cost effectiveness, according to which there should be a reasonable relationship between the cost and the effect of the treatment. But in the public debate, there were some arguments for a revision of this platform in favor of more utilitarian considerations. However, we argued that to deviate from established and anchored principles for prioritization in a time of crisis would cause insecurity and confusion. This, though, does not rule out that a principle of need could be more specified so that a patient in a better overall health condition could be taken priority over a patient with less possibilities to benefit from a treatment. In this way, biological age, but not chronological age, could be used as a criterion. It seems that the national recommendations to prioritize according to the platform in some places were unfortunately preceded by regional and local directives in Sweden. According to some local directives, elderly living in elderly homes should not be sent to intensive care, but instead receive palliative care. While introducing, at least in practice, age as a criterion, these directives were obviously a violation of the priority platform. They may also have resulted in an increased number of elderly dying from COVID-19. But fortunately, due to an impressive demonstration of strengths, the Swedish intensive care generally managed to care for all patients in need. So an acute need for prioritization never emerged. The corona pandemic is also challenging for research ethics. When a new pandemic strikes, there are no pharmaceuticals and no vaccines available, but of course an urgent need. Vaccine development is a long, complex process, often lasting 10, 15 years. How could this time be shortened? Is it perhaps ethically justified to limit the regulations for research on human beings and, for example, allow persons to volunteer for potentially hazardous research? Although this kind of deregulations could be motivated by the need for a vaccine and the lives that could be saved by mass vaccination, we argue in our report for caution here, and I quote from the report: "It is particularly important to maintain requirements for a science-based hypothesis and an adequate methodology in times of crisis, when poor research can do a great deal of damage to both individuals and society." End quote. Of course, many ethical choices are also made by individuals during a pandemic. Professionals in healthcare must decide if they should work or not under hazardous working conditions that appeared not least in the spring. Here, professional virtues are important as guidelines. and individuals must decide whether to follow the corona instructions even when they limit the liberties and well-being. They must also decide whether to be vaccinated or not when we have a vaccine available. These decisions could be guided, I think, by classical virtues like prudence, justice, temperance, and not least courage. Sorry. A journalist asked the chair of the Folkhälsomyndigheten if there is a duty to vaccinate. He did not say either yes or no, in my way, surprisingly. I think he should have answered yes, for the sake of the community that a person is a part of. Our report was published in May, and much has happened since. It's of course too early to evaluate the Swedish corona strategy. But of course, our report doesn't have so much effect on the strategy. It's still important in hindsight to ask what values were really realized in practice and which were not, and how did this correspond to the discussions that we have, for example, in our report. There is in fact now a Corona Commission is already appointed and working that will continuously evaluate the strategy. And the first report from this commission will be published in December. Let me, though, finally mention one sector that stands out as especially problematic from an ethical point of view, and that is the care of elderly. I think it was a combination of unfortunate circumstances has led to a high number of deaths of elderly people, and as a consequence of the corona pandemic, and also some other very unfortunate rules and regulations. There are at least 5 points here I want to make. First, as I mentioned, there were local directives that elderly living in elderly homes should not burden intensive care, which probably implied that some elderly were refused care that could have saved their lives. Second, decisions for treatment, including decisions for palliative care, were sometimes taken by doctors at a distance. This fact is obviously in contrast to good and trustworthy care. Third, there were already at the beginning of the pandemic serious problems in elderly care due to lack of resources, privatization, employment at an hourly basis. Many homes were unprepared for a pandemic. Fourth, the local communities are responsible for elderly homes, not the regional healthcare. And in spite of the fact that there are multi-morbid patients living in these homes, they have still insufficient medical resources. Fifth, another problem. Prohibitions to visit elderly homes because of risk contagion had the sad implication that many elderly died alone. In fact, I come across a study shows that 85% of deaths in some elderly homes in one region happened without the presence of a relative, which is of course a very sad figure. The conclusion drawn is that in conflict with the ethical platform that I presented earlier, elderly have been lower prioritized than other groups during the pandemic, perhaps mirroring an ageist view in the Swedish society. So let me now sum up some important ethical questions in the times of a corona pandemic before I end my presentation. How to achieve a just global distribution of pharmaceuticals and vaccines? Which corona strategy is ethically justified? Why? How should patients be prioritized in intensive care if there is a need for prioritization? Which prohibition in elderly homes can be ethically justified and which are not? What ethical principles should guide research for the acute need to find vaccines? Before I finish, I want to give a warning, which is very obvious, of course. It's easy to be wise in hindsight. Decisions during the corona pandemic have been made in utmost uncertainty. So thank you.
Thank you very much, Göran, for a much thought-provoking talk. Before we proceed, I'd like to invite all of you in the attendance to raise questions, and the way you do that is with the Q&A function, which is in the bottom of the Zoom window. There you find the Q&A, not the chat, but the Q&A function, and the questions will be sorted and forwarded to the speakers. So thank you, Göran, and now is the time for the first commentator, which is Kirsten Kyvik, who is a professor and head of the Department of Clinical Research at the University of Southern Denmark. And she is also a member of the Nordic Committee on Bioethics. Please, Kirsten.
Thank you very much, Ingemar. And thank you very much to Professor Collste for a very interesting talk. I would also like to congratulate the Council on this very thorough report that I have read with great joy, actually, because I think it's so comprehensive. I do think I should also start with kind of a self-declaration, because my comments and my questions are related to the fact that I'm not an ethicist. I'm a medical doctor who spent most of my career working as a researcher at the university and as a leader of clinical scientists. And besides that, I'm working with research ethics. And I have two main points I would like to take up here. And I'm sure Helge Solbakk has a lot more. But the first point is the question of how to balance the rights and interests of the individual person and the public health, folkehemmet, as Professor Collste named it, because I do think when you look back and read about pandemics in the Middle Ages, it seems that it was actually public health that was taken more as a priority. But in our time, we have a lot of focus on human dignity, human rights, etc., which means that you cannot take the same decisions as you could in the 13th and 14th century. And this means that we have to try to balance this. And that is something that I would like to hear Professor Collste's view on. Can we do it? And if you think we can, how?
Thank you, Kirsten. I think that Göran can answer after Jan Helge's commentaries as well. So please, Jan Helge, you are a professor of medical ethics at the University of Oslo in the Center for Medical Ethics, and very well-known ethicist also on the international European level. So please, Jan Helge.
Thank you very much, Ingemar, for the invitation to comment on Göran's talk, which I found extremely interesting. I would start with where he started, the global perspective. And I think one of the huge challenges is that although we proclaim and put emphasis on global solidarity, global justice, it is a fact of the world. Göran made this interesting distinction, an important distinction between facts and values. It is a fact of the world that when we consider the 5 vaccines that seem to be most promising. 13% of the world's population has already bought up more than 50% of the stock that will become available. So I find it very interesting that the present rector or president of Karolinska Institute, he and a colleague, they published an article in Nature Medicine a few weeks ago, where they argue that the principle of universal health coverage needs to be paired with a new principle they called universal health preparedness, because it is a fact of the world that every time something like this happened, we go back to 2009 and the swine flu pandemic, although one preach the principle of universal coverage, it is a fact that it is the rich countries that get access first, and the poor countries always have to wait. So what is lacking in these principles, both of global justice, universal health coverage, is a time dimension. How should we plan in such times so that all people in the whole world get access at the same time? I think that is a huge challenge. My second comment relates to this fact-value distinction, and I liked very much Göran at the end of his talk. He introduced an extremely important third concept, uncertainty. Because, okay, this pandemic is now around 8 to 9 months old. We know much more now about this disease, how it spread, early symptoms, death rate, also related to age distribution, but there is still so much we still do not know. And that brings in this very important third dimension between facts and values, uncertainty, and how to make wise both health policy decisions and moral decisions in times of deep uncertainty. I think I will stop there for the time being.
Fine, thank you. I give the word to Kirsten. You had one more comment that you would like to put forward.
Yes, that is not a comment that I specifically want Göran Collste to comment on, but it's a question. It's a comment with regard to research ethics, which I think is extremely important in these days, because what I, as the chairman of research ethics committees, have seen this year is some of the things that is mentioned in the report. It's about labeling your pet research as COVID, both in order to get it quicker through a committee, but also in the hope that a committee might see it as more justified this year than it would have been seen last year. And I think that is a bit of a problem, that we have people who are that entrepreneurial in the research communities. And I'm happy to say that the ones we have seen have not been deemed as justified and has been turned down, but it's a problem that is out there. Another thing that is also a problem, I think, is the uncritical canalization of funding to COVID, because all of the usual ways of ensuring quality of research have also, at least in Denmark, been put aside for some from some funding agencies' side, and I think that is also a big problem. I agree completely with Smer's report that we have to act quickly, to have a fast lane for COVID projects, but I do also agree that we cannot just be completely uncritical when it comes to quality, and that goes for funding and it goes for reviewing projects. So that is something I think is very important, because if we are going to take decisions based on science, it is so important that science is as correct as possible. Thank you.
Thank you, Kirsten. And thank you, both commentators. Now I give the possibility for Göran to answer most of them or all of them, please.
Well, I can maybe comment on them, because I'm not sure I can answer some of these questions, because they are, of course, very difficult and controversial, and I tried to take notes here. And Kirsten's first question was how to balance individual rights and public health. And this, of course, is very controversial. And we know from these demonstrations and all over the world, I suppose, people are refusing. And we have seen even violent demonstrations in Germany and in the US and so against these kind of restrictions, followed by a lockdown of the societies. And in Sweden, we haven't seen any of these kind of demonstrations because of the kind of relaxed policies that has been applied here. I think we have some critical comment in our report on the kind of liberal individualism that should be taken, that has, so to say, taken over decision making in many ways in healthcare, and that's also when it comes to other aspects of healthcare, at least in Sweden. And I share this critical view myself. I think it's quite reasonable to argue that from a public health perspective, which means the welfare of everyone in the society, and then also based on scientific evidence, could be paternalistic here, because it is in everyone's interest. And if there are some people who doesn't believe so, I think they have to learn that this is what they and at least in most of our countries, the protection of human rights are, of course, anyway so important and secure that for this kind of temporary policies are justified. And for myself, I would even prefer even more stricter regulations in Sweden, for example. That's strange that the freedom still that it's possible for perhaps the young people to go on partying and so, and don't care about the restrictions, and then therefore spreading the virus, which will hit these old people who can die as a consequence. I mean, that's kind of balancing between individual rights and public health that is very questionable. In this kind of situation we are in now, I think we need much more stricter regulations in Sweden. So that's my comment on your Kristi's first question. Jan Helge seems to agree with our view and my presentation on the importance of global justice when we discuss all these issues. And I think there are two good reasons. Basically, of course, that each of us have the same value. I mean, we in some way argue and look at the world as if we in the rich former colonial powers are in some way still more valuable than people in the South, which and as you said, I also noticed in Swedish TV I think the person who was responsible for vaccine politics said something about, well, then we have bought so much, we can use it ourselves, and then there could also be some left we can give as to poor people in the south. So that was kind of the attitude that we in some way have priorities, but there are of course no reason for that. Like, no reason. It's just power, and by the other reason, of course, that we all, that it's also for our own self-interest, that as long as the pandemic will continue somewhere in the world, it would be a threat to all of us. So I think that there is good also self-interested reasons for this spread. And there are some interesting work done. You mentioned this paper by the Karolinska's director. The WHO has of course been very aware of this problem, I think, from the beginning, and questioned by, of course, Donald Trump and other persons, but still, and there's in Science a very interesting article by Emmanuel and other ethicists about how we could distribute in a just way. That's a way we have to continue argue for the importance. Uncertainty was the question that John Helge. How should we act rational, reasonable in a way with so many uncertainties? And perhaps we should refer to here again the precautionary principle, which would be made alive again here, that we must argue that if you see the worst outcome, we have to avoid that. We have to take precautionary actions so we avoid these unfortunate possible consequences. It's better to have more caution than less. And Kirsti talked a little about research ethics. Yes, research ethics is there's a kind of a flow of money to all kinds of projects. I think you just mentioned it yourself, and I'm sure you are right. I don't have any more comments than what you said about that. Okay.
Thank you, Göran. I have a question to all the three of you. And Göran touched upon the phenomena that Sweden is an outlier. You said that we have in some ways a peculiar attitude, the soft power or the soft recommendations. And you talked about the concept of folkhemmet, that this should be an example of that, but it could be seen as a emphasis on the individual. And I have a question from the audience attendees that touches upon this that I would like to ask. Numbers suggest that the soft measures applied so far are too soft, I guess in Sweden then. Protect the individual's choice, but thereby endanger the community. Can individual freedom be more important than collective safety? Feel free, all three of you, to comment on that. Jan Helge?
Well, yes, because this question relates also to what Kirsti mentioned in relation to research ethics. And in research ethics, we have this core principle that the interest and well-being of the individual should have priority over the interests of science and society. And the reason for that is the level of uncertainty, because in a research context, we do not know for sure what will be the consequences of this intervention. While in a clinical context, for decades, the principle has been that, for example, in a situation of a dangerous infectious epidemic disease, it is the duty of the physician, for example, to isolate the patient even against his or her will because of the interest and safety of the society. So, but now the situation is, and this relates to the difference between Sweden and the other Nordic countries. When this pandemic started, there was so much we didn't really know about the disease. So the level of uncertainty both when it came to, okay, what kind of research projects should we design and conduct, and what kind of care and treatment activities should be given priority. And that raises the question, well, should we then make use of this principle, the priority of the individual, which is the principle in a research context, or should we use the principle, the priority of the society, which is in such situation, the core principles in a pandemic situation? And I think the strategies that were planned differently in the Nordic countries were completely justified because of this level of uncertainty. But then the challenge is, the more we know, the more we see the difference in death rates, maybe then it is time to change the course. And finally, to teach this comment, I think that these dangerous arguments that has been promoted by several also very prominent bioethicists, that in exceptional times, there is a need for exceptional ethics. I think that is, first, historically, it is flatly wrong. The core principles of research ethics that we have ended up with were born as a result of catastrophes even bigger than the present catastrophe. And to deviate from these so importantly fought principles, to speed up, to cut corners, I think that is extremely dangerous.
Thank you, Jan Helge. Göran, do you have anything to comment on this?
I agree with what was just said, and I think I comment on the balance between individual rights and the communal interest earlier, so I can let other persons come in here and raise questions and discuss. Yes.
All right. Kirsten, any comment at the moment, or should we proceed?
I think we should give the rest of the audience a possibility.
Yes. So next question is, don't we have quite deep uncertainty regarding other medical issues as well, including physical and mental conditions induced by restrictions, especially long term? Göran?
Very good question. Yeah, may I comment on that? Because it's a very good question. I think we have also in the discussion had a focus, and that was, I think, some of the justification in the spring for the Swedish strategy, that there are other problems caused, health problems caused by lockdown, for example, people sitting in their apartments, isolated, and one could foresee perhaps higher rates of suicides and other violence in the home. We can see also from, if the economy would go down through the lockdown, there would be problem with unemployment, and there will be also, we know, unemployment also leads to both illnesses and even deaths. If we should count this, so to say, finally the strategy's outcomes when it comes to lives, missed lives and so on, one could, I'm not sure about the result, but so I think that's a good point, that we have to take into consideration all these consequences from strict lockdowns. From what I have seen, but I think that I'm not really perhaps updated empirically, but there have not been the results in statistics of a higher suicide rates or something like that, at least in the Swedish case, where we have had a very mild or soft lockdown also, but still some kind of isolation. I mean, people are feeling very isolated, and not least in the elderly homes, for example.
Yeah. Thank you. I think we can have time for one more question to discuss, and also to all three of you. Using a Nordic perspective, there have been some dissimilarities between who is to decide. Is it politicians or the experts? In Sweden, there has been a preference for the public health agency, and the physicians to decide, maybe a bit of change the last couple of days or weeks towards some more heavy political emphasis. Whereas, as far as I know, the politicians have been at the forefront much more, both in Denmark and Norway. What do you, if I ask you, Göran, first, what do you think about this balancing? Is there an ethical aspect of this as well?
Yeah, one of our principles is, of course, exactly what a scientific basis or something like that. I think that's the positive side of having this reliance on Folkhälsomyndigheten, that there seems to be a well-founded scientific basis for decision, which you cannot expect politicians would perhaps in the same way. Politicians seem more to perhaps listen to the opinions which could be then coming in contrast with what is scientifically well-founded. So in this way, there's an argument for the sort of Swedish model. On the other hand, the problem is that politicians can avoid responsibility through this way. They can blame the Folkhälsomyndigheten if something goes wrong, and they can take the credit from something that goes right. That's a real problem, and that's a problem I think we can also see in Sweden. So that is both argument for and
against. Thank you, Göran. Kirsten, what Danish perspective on this question?
Well, in Denmark, we have had this lockdown very early, as you probably know. It has been based on scientific advice from our scientists, equivalent to the Swedish ones, but there is by now no doubt that the politicians have taken further measures to ensure that we didn't get Italian consequences, which is quite honestly what has been said as the reason for the very strict lockdown in the spring. I think from the Nordic perspective, we are in some ways, rather lucky. When you compare to other places, I think whether it has been politicians or public health scientists who have taken the decisions, we are not at all in the same situations as in many other places. Maybe due to the social structure we have in the Nordic countries. And I'm not an ethicist, so I'm not going to say something bright about this, but I do think the Nordic countries have some social structures in the countries that gives us it makes things a bit easier for us. Despite having COVID and people dying, etc., we are not at all in the same situation as they are in many other countries. I think that's all I can say right now.
Thank you, Kirsten. Time runs fast, and it's one principle behind our webinars that you should not run into Zoom fatigue. And so therefore we have to round up now, but if I can have the next slide, please. We are continuing this series of webinars. The next one will be in Norway, and then Iceland and Denmark. The dates are not fixed yet, but there will be 3 webinars in this series. And the next slide, you can see the website where you can see the announcements and also the hashtag about this. So thank you very much to all the 3 speakers, the keynote speaker, Göran, and the commentators, Kirsten, Jan, Helge. And I think this has been a very fruitful webinar, and we meet again based on an Oslo webinar in February, I think. So goodbye to all of you, and thank you very much.